You're welcome to my channel. Today I'll be rounding up on infective endocarditis, and that will take us through the treatment of infective endocarditis. If you haven't listened to other presentations, please kindly listen to them so that you can understand what we are doing here as per the treatment. Without further ado, let's go. Infective endocarditis, if picked early, may not go through all these departments. If not, it's very, very likely that all these departments will be involved. So it's going to be multidisciplinary approach: cardiologist, pharmacologist, microbiologist, radiologist, even cardiothoracic surgery or neurosurgery with cardiothoracic surgeon or neurosurgeon involvement. Infectious disease experts, nephrologists, or neurologists, all could be involved. Let's remember prevention and prophylaxis. Full info can be found if you click on this very link. As for prevention and prophylaxis, the diagnosis must be made before treatment and must be accurate, must be precise. So, click on this link. This will take you to all the steps as per making precise diagnosis of infective endocarditis. We will give ourselves the one, setting ourselves on motion, telling ourselves don't delay. Make correct diagnosis quickly. Do we need to go ahead with empirical treatment or not? Definitive treatment will come once the lab result is here. If we delay, there may be certain issues like stroke, septic pulmonary emboli, heart failure, sepsis, and the individual may die. Fatality. Empirical antibiotics. We all understand what this term is all about, right? That is giving your antibiotics based on the knowledge of probable causative agents in your domain. So we'll ask ourselves certain questions. Is this patient stable? If the answer is yes, the patient is stable, then we don't need to rush for empirical antibiotics. But if the patient is in acute phase and unstable and we need to take blood samples, that is not even the issue. Once we find that the patient is unstable, we should go for empirical antibiotics. The reason why I brought blood sample into this is so many authorities will state whatever they think is appropriate based on their own practice, right? So if the patient is unstable, first thing first, we want to save that life. So antibiotics must start. Then we'll start working on taking a blood sample. Some will say, don't give antibiotics even if the patient is unstable until you have taken 2 sets of blood culture samples. But there's a risk associated with that. It is not okay to hold your antibiotics, counting the time, because the samples should be taken 12 hours apart. So counting the time for 12 hours before you can take the second sample. So even if the situation is that you have started your empirical antibiotics and within 48 to 72 hours of the onset of antibiotics intravenously, you can still take your sample. Then another question is, are there allergies? When you are trying to select the antibiotics, you consider that. Then you are familiar with the microbe. If that is the case, then you can go ahead to give that antibiotics because you are familiar with what is likely going to be the case in your domain. And are you dealing with native valve or prosthetic? That will guide. Methicillin-resistant Staphylococcus aureus or vancomycin-resistant Enterococcus, is that not happening in your domain? Or you are dealing with carbapenemase producing organisms. So if it depends on your environment. Then you'll be able to determine the specific antibiotics. And if you're confused, you can just call on your infectious disease expert or your clinical pharmacologist or pharmacist. We must swing to action and make that quick determination for immediate surgery or not, and consult to cardiothoracic surgeon. But while doing that, let antimicrobial agent to be going on, okay? Intravenously, let it start. The left-sided native valve will need immediate surgery when we are faced with heart failure, okay, or intracardiac abscess. And the right-sided native valve will require immediate surgery when there's large vegetation, or we are faced with recurrent pulmonary emboli, or we are faced with resistant bacteria and bacteremia. Ventricular septal defects or patent ductal arteriosus are high pressure areas that must be fixed. For sure, we need antibiotics because 80 to 90% of infective endocarditis will be caused by bacteria. So, selection for definitive treatment will be based on the susceptibility result from the lab. Remember, we have gone past empirical at this stage, right? And we're going for high dose, and the high dose will be delivered intravenously. And the selection of the specific agent will be based on susceptibility and whether we are dealing with native valve, prosthetic valve, intravenous drug users, and whether this patient is in need of valvular surgery or not. Then, many authorities will tell 4 to 6 weeks, but remember, this counts. The duration will start on the very first day that will record the first culture negative. So I would just say, put your mind on going for 6 weeks. Possible agent. Please, you don't have to follow this rigidly. No. Discuss with the pharmacist, with infectious disease experts in your jurisdiction. Do you know why? It depends on what is available in your jurisdiction and what you think will work for your patient. But many will likely go for vancomycin. Remember, that will not be helpful in vancomycin resistance heterococcus phase, right? Some will go for ceftriaxone, but I would suggest you should find out if there's severe reaction to penicillin in the past, anaphylaxis in the past due to penicillin. Better be careful with ceftriaxone today. And then some will go for tazocine, that is other agent that the microbe could be susceptible to, right? The lab result will guide. So some will combine piperacillin and tazobactam in tazocine. Some will go for ampicillin with sulbactam under unacin. Some will add aminoglycoside along the way. Some will add rifampicin if they are dealing with prosthetic valves. But gentamicin is no more used frequently in advanced countries, some parts of the world. If that is what is available to save the patient, some are still using it. Some are still combining ceftriaxone with aminoglycoside. It depends on what the protocol is in your department, particularly department of cardiology. So it depends on what is obtainable. The infectious disease experts and your cardiologists, clinical pharmacologists, pharmacists can all guide. All we want is to save that life. Still on possible agent, and don't be upset that I'm taking a lot of time on the selection of antibiotics because that is the core. Besides the surgery is the antibiotics use, okay? So the use of penicillin could be considered in S. viridans and S. bovis. S. bovis is the old name, is now S. galolyticus. Okay, penicillin could be considered in those two agents. Two bacteria. But there are certain factors before you select penicillin here. Apart from the allergen, then penicillin will be okay if you are dealing with native valve problem. It is not okay if you are dealing with prosthetic valve problem. No, it is not okay when you are faced with septic thromboembolism. It is not okay when vegetation is large enough that is greater than 5 millimeters in diameter. If there are certain complications like heart failure, arrhythmia, and pulmonary embolism, then you may consider penicillin if your agents are S. viridans or S. bovis, formerly now known as S. galolyticus. So we may consider penicillin. Of course, allergy. Still under possible agent, for sure, no antiplatelets, no anticoagulants here. But whether or not you can use antithrombotic agent would depend on your conversation with the cardiologist and the experts that will be able to guide you. So clinical pharmacologist and pharmacist. A tree cannot make a forest, for sure. You need to discuss with someone. Okay, I think we are done with the use of antibiotics. How about surgery? Immediate surgery in these cases. Well, surgery is better within the first 7 days of infective endocarditis. Preferably, if you can get it done in less than 7 days, that would be great. But immediately, the antibiotic is already in the system and you continue even while planning for the surgery. So, under what conditions? Number one, if the causative agent is a fungus, or you are dealing with a gram-negative bacteria, and you have valvular stenosis causing regurgitation or heart failure, you better refer to cardiothoracic surgeon. When there is high pressure defects on the high pressure areas like ventricular septal defect or patent ductus arteriosus, you don't need to waste any time. Another indication is pulmonary hypertension, also cardiac conduction defects leading to arrhythmia, because if the heart is completely blocked, no atrioventricular node blockage, then you know what that means. Penetrating lesions, recurrent septic emboli that is difficult to treat. If the vegetation is pretty large, greater than 10 millimeters, or there's persistently positive blood culture, or prosthetic valve dehiscency is present, or we are faced with abscess formation on the valves, or there's relapsing infection with the presence of prosthetic valves. All this will warrant surgery. Monitoring will be required, and it will be helpful with echo, transthoracic, or transesophageal. That will be based on clinical judgment. For example, if you are now faced with new complications, or there is stroke or embolic conditions like pulmonary embolism, or there is heart failure that is so troublesome, echo will help us to detect the size of vegetation that is still persistent or intracardiac abscess. Then we'll know whether we'll call for surgery this time or we'll continue with the antibiotics. Then colonoscopy will become useful. Now, colonoscopy is an issue here because it can go in both directions, either through colonoscopy, somebody could come down with infective endocarditis, or colonoscopy can help us to find out what is happening to the colon in anyone with infective endocarditis, and the agent that is responsible is group G streptococci or Escherichia coli. If we are faced with those two groups of bacteria, then we will have to call for colonoscopy, particularly in an individual with either family history of colorectal carcinoma, or the individual is 50 years and above. Then we call for colonoscopy. Remember, if group D streptococci or E. coli are the culprit, or the individual's family history of colorectal carcinoma, or the individual is greater than 50 years, we call for colonoscopy. Still on monitoring, some will disagree with this, that you can have repeated blood cultures, but I have 2 points on that. Number one, you are going to make the determination or the duration of the antibiotics based on the first day of blood culture negative. But how will you get there if you don't have repeated blood culture? Number one. Number two, you will continue to have repeated blood culture if signs of infection is still persistent. But some will argue against that as long as there is bacteremia, you continue to have fever. So whether you belong to the school of thought A or B, please continue to have repeated blood cultures till you are comfortable to do otherwise. And the clinical features that will guide could be picked right here. If you click on this link, that will lead you to the signs and symptoms of infective endocarditis. The prognosis is not so good. About 25% of affected individuals will die. Mortality is about 25%. 18% will die in the hospital, while 50% will have septic and embolic complications. The prognosis is not so great. Great, the patient is fine. He or she can go home. How about follow-up? You can click on this very link to give you full info on prevention and prophylaxis. But just briefly here, I will state here that we will counsel people that are taking intravenous drugs. Okay, if there are devices in situ and they are responsible for these, we'll get them out. Catheters should be removed. Dental hygiene should be encouraged, and prophylactic antibiotics as is appropriate. And then we'll also do echo after the last dose of antibiotics. We can add to the lab to know what is happening with erythrocyte segmentation rate, white blood cell count, C-reactive protein, and then we'll repeat blood cultures as it may be appropriate. That I've come to the end of this presentation, but remember to click on this very link for more info on prevention and prophylaxis. So this is the end of our presentations on infective endocarditis. It is my desire that anyone with these infective endocarditis problems will not even get into complications, will get out of the problem, and we will help them through by making accurate diagnosis and prompt intervention. Thanks for listening. Please remember to share this on your platform. Remember to subscribe to my channel. I appreciate it.